Good evening, friends. Welcome back. Once again, we are back with our continuation of allergen immunotherapy series. And as you are aware, that this week we have discussed in deep, starting from where allergen immunotherapy actually started, how the origin came, what difficulties researchers faced, how it has evolved till date, which are the different modalities which we are having till date now, what are the conditions, who are the ideal patients, what should be the allergen selection criteria, what should be the length, what should be the monitoring parameters, and how we should go about allergen immunotherapy even in special scenarios like pregnancy, pediatrics, immunodeficiency, and all those. So now we are at a very crucial juncture at which we understand that okay, allergen immunotherapy is a very important tool. From this point, where we will be going. So today's webinar will be something which is like a futuristic view that tomorrow what we can expect, or probably day after tomorrow what we can expect, and with for whom to moderate that we have an extremely talented pediatric allergist from Mangalore, Dr. Soundarya Mahalingam. She is the consultant uh, at Mangalore Medical College, and we are very fortunate that she is today available to us for moderating this very important webinar. So, Dr. Soundarya, we welcome you here, and you can please start with the webinar.
Thank you, sir, for the kind introduction and for welcoming me to the webinar. So today's webinar, we have three eminent pediatric and adult pulmonology and allergy specialists, and I am very honored to be moderating this. So our first speaker is Dr. Karthik Nagaraju, who is a top pulmonologist and respiratory medicine therapist, specializing in allergy and asthma management, both in children and adults. And sir has lots of publications and research work to his name and has a very good allergy center of his name as well. So with this very small introduction, though sir deserves a lot more, I now invite him to kindly present his topic on biomarkers in allergen immunotherapy management. Over to you, sir.
Thank you. Thank you so much, Niraj sir. Thank you so much, PI and IAP and Madam Thoundirya ma'am for the kind introduction and the welcome. I'll share my screen. So is this now visible as a PowerPoint?
Yes, sir. Yes, visible,
Right.
Dr. Karthik,
Yes.
visible.
Thank you so much. So I'll begin. Thank you so much, ma'am.
Right.
So in continuation with the amazing work that has already happened over the last 1 week, we've had an extensive discussion about allergen immunotherapy, and sir said very rightly from grassroots till today, and we are trying to look at how can we look at it from a futuristic point of view. And some of the things that have or areas where there is some gray zone or gaps in our current knowledge in allergen immunotherapy includes, can we identify something where we can predict therapy, predict response? Can we find out somebody, when do we start it, when do we stop it? Do we find out somebody is responding or not responding? Is there any objective way of analyzing these data? So I thought that my talk, I would be concentrating more about focusing on biomarkers as a role in monitoring allergen immunotherapy and how can we personalize treatment based on them. So we'll first look at some of the pathomechanisms of allergen immunotherapy. Briefly, just recollect those points, because recollecting them will help us in looking at what are the biomarkers which are useful in allergen immunotherapy. Subsequently, what is the relevance of each biomarker and how do we use them, and what is some of the future biomarkers for monitoring allergen immunotherapy. So briefly, allergen immunotherapy is based on the natural allergen exposure, which leads to your typical innate lymphoid cells and innate dendritic cells are stimulated, which leads to the dominant Th2 or a type 2 T follicular cell dominant reaction because of several cytokines, interleukin 4, 5, 13, and subsequently plasma cell class switching to an IgE dominant reaction, which also subsequently binds with your mast cells, basophils, and eosinophils, and also result in the ultimate release of mediators and ultimately immediate and delayed inflammatory reactions. So allergen immunotherapy, we have already discussed about it by several routes, by stimulating the innate dendritic cells and by stimulating a regulatory aspect of the dendritic cells. So regulatory dendritic cells dominates and try to shifts the immune response towards a Th1 mediated reaction, such as your regulatory T cells and regulatory B cells are also dominant with the presence of interleukin 10 and also presence of switching from an IgE mediated reaction to an IgG dominant response, which also go and bind to your IgE mast cells. So these are the inert immunoglobulins which are produced, and these are ultimately also responsible for reducing the reactions of your mast cells, eosinophils, and basophils, eventually leading to reduced your inflammatory markers, and thereby clinical response. So overall, when we look at allergen immunotherapy, we say that we have a timeline of responses, and there are several markers. This is a very well displayed, very commonly understood image, but I'll just reinforce that mast cells, basophils, and eosinophils are some of the earliest responders in allergen immunotherapy, where then their numbers drop within few weeks and they continue to stay down as long as allergen immunotherapy is administered. And similarly, when we look at specific Ig levels, there is an initial rise followed by a fall phenomenon, and these specific Ig levels also tend to become low over many years of allergen immunotherapy administration. The inert or the blocking antibodies like IgA or IgG4 take some time to increase, and it takes several months to maybe years also for their levels to grow up. And this is why immunotherapy duration of treatment is at least 3 years and longer for these regulatory T cells, B cells, and immune cells to dominate and create those particular Th1 mediated responses. And we know that IgA antibodies are predominantly produced by mucosally dominated therapy like sublingual immunotherapy, and subcutaneous immunotherapy produces a predominant IgG4 response. What we will be doing in this part of the seminar or this particular presentation will be to assess what are the biomarkers that we can measure and how can we do it currently in our practice, and what is the outlook in the future. So biomarker per se is an objectively measured characteristic that needs to be objective. It's not a subjective measurement. It is an indicator of the normal process that happens in the biological reaction or a pathological process. And this also occurs as a response to a therapeutic intervention also. So the biomarker is usually a diagnostic or a prognostic biomarker, and it can also have a predictive role and also acts as a surrogate of clinical response while also helping in monitoring disease progression. An ideal biomarker would be something that is easily quantifiable, sensitive and specific, cost effective, which helps in stratifying the risk of progression to diseases also. So allergen immunotherapy from earlier used to be a mass treatment. Everybody gets the same treatment, same dosage. And then we started looking at stratified therapy where we phenotyped patients. And this was something of a yesteryear thing still. We try to identify patients who are responders and non-responders, or clinically, we identify patients who are major allergen or minor allergen positive to identify those who can get stratified therapies. Now we are at a time where there is a precision therapy where we have certain markers which are currently etiological related, so that based on which we are able to accurately diagnose somebody with a true allergy or not a cross-reactive allergy, and thereby we're able to improve the allergen immunotherapy or give a more better immunotherapy responses. But what is tomorrow is something like using biomarkers in helping us as a predictive tool, that even before starting immunotherapy, can we predict responder versus non-responder, and that is now called as a theratype concept. Wherein from a phenotype is extrinsic characteristics, but putting all the characteristics like phenotyping and endotyping and all, put these together and predict responders versus non-responders, and that is what is called as a theratype. So there are several potential biomarkers, and for that understanding, I think we need to look at it from what are the changes that occur with immunotherapy. So if you look at it, there are certain antibody changes like reduction in the IgE levels and increase in the IgG4 levels. So these can be grouped together as antibody biomarkers. There are certain reduction in Th2 cytokines and T cell and B cell changes. So those can be grouped together as cellular biomarkers. Changes in the cytokine levels like TGF beta and interleukin 10 would be contributing to cytokine biomarkers. Changes in the response of basophils and eosinophils would be basophil activation markers, and also in vivo biomarkers. So overall put together, these would be the core headings under which my presentation of biomarkers in immunotherapy would be. So let's begin with antibody biomarkers, which is the most common and sometimes easily measured questions. So sometimes there are questions asked by not only patients, by other physicians also. Can I just check antibody levels before starting? And if I'm going to repeat the antibody levels of IgE level, total IgE or specific IgE, will these change? If there is a change, does it mean that I'm improving? So the question is, there are several answers that we need to look at. There are several steps we need to take before we understand what response is possible for each patient. So this is a paper where there is a Yaki position paper by Mohammad Shamji et al. They looked at the biomarkers for clinical efficacy to immunotherapy, and they have clearly told that the total IgE as such is a very poor diagnostic tool for diagnosis of allergic diseases, and their role in monitoring allergen immunotherapy is even more redundant. So they're not especially useful as a predictive tool at all, because they are having a heterogeneous response. Sometimes there is an increase in total IgE levels, sometimes there is a decrease in total IgE levels, and because the initial rise followed by a decrease, it is difficult to say when to really repeat a specific IgE or a total IgE levels to identify somebody as a responder. So if you look at specific IgE levels, now we know that specific IgE is one of the important diagnostic marker and part of a diagnosis before even initiating immunotherapy. And it includes not only the serum IgE levels, it also includes the bound IgE that is detected using your SPT. So both using your SPT or specific IgE, we are able to identify the right person who will be diagnosed with an allergic disease. And this is a part of your routine inclusion criteria for immunotherapy. And just we have seen in the previous slides that there is a rise and fall. So but this does not have a clinical relevance. Just because there is a rise does not mean that they will have more symptoms in the early phases, and these there is a decrease doesn't mean that there will be a less response. But responder versus non-responder has a poor differentiation as a predictor, and therefore specific IgE per se is not recommended tool as a monitoring tool during immunotherapy, especially in situations like food allergy, where milk, egg, or certain foods are being attributed, whether we need to proceed with oral food challenges or open food challenges. These tools, specific IgE monitoring, can be used to predict whether they will develop a positive reaction or a negative reaction. So some papers and some interest was developed few years ago on this important ratio called a specific IgE divided by total IgE ratio. So this was a very interesting paper. This was based on one particular study using grass pollen immunotherapy alone. And they said that if the ratio of more than 16.2% of specific IgE upon the total IgE ratio predicted successful outcomes in immunotherapy. There had some issues with the study. It was a very strong paper, but it was only monosensitized paper to study patients, and there was only to pollen allergy. It had a high sensitivity and specificity, but this was not replicated in other studies, and there is generally an increase in the specific IgE and total IgE ratio during immunotherapy. So sometimes it seems easy, it seems sensible to actually think about it, that if the contribution of this specific IgE is high to the total IgE value, then therefore it must be the major contributor. And if you have a high value, you should respond to immunotherapy. But the issue here is that specific IgE is tested using KUA per liter. And if you look at total IgE, it is measured in international units per ml or liters. So this is two different technologies. Two different machines are also sometimes used, so they cannot be used reproducibly in many data, and as such it is not extensively known yet to predict response to immunotherapy as of right now. So total IgE is easy to measure, but there is no correlation, so it's not recommended. Specific IgE is serum based, easy to measure. All that is there. There is a rise and fall phenomenon, but there is no functional relevance or clinical relevance or predicting outcomes. And this is not recommended as an aeroallergen immunotherapy. However, it can be used for your food immunotherapy patients or oral immunotherapy patients. The ratio is a potential biomarker. It is excellent tool, but the difference in the platforms in the is present. So if you use the single plex platform for measuring total IgE and for measuring specific IgE, such as if you use immunocap or if you use your multiplex platform in the same setting, it might be there, but then we don't really have a specific cutoff to say. Something that I've seen in my current practice over the last, I've included specific IG by total IG in my experience, is that the ratio tends to rise over the first few months of immunotherapy. And if you see a rise, it is a good sign that at least your immune system is getting triggered and you're able to see at least the initial rise in specific IG levels following a good challenge with allergen extracts. So can we look at other immunoglobulin G related biomarkers such as your blocking biomarkers? And the most extensively and the most, currently the fascinating antibody that everybody is looking forward to eagerly is your IgG4 antibody, which actually blocks the specific IgE, blocks the basophils, blocks your mast cells, and thereby reduces all your systemic and local reactions. And therefore there has been an increase of nearly 10 to 100 times increase in the specific IgG4 levels after starting immunotherapy. And this is particularly noted in patients who had started on subcutaneous immunotherapy, probably because of their systemic or subcutaneous dosage rather than a mucosal targeted challenge. But we don't know exactly why subcutaneous immunotherapy leads to an increase in the IgG4 levels. So post immunotherapy, there is an increase, but these levels tend to fall down over a period of the next 2 to 3 years. So the sustained IgG4 levels are not known to occur after initiating with immunotherapy. So, however, the people have noticed that tissue IgG4 may be a better marker of nasal sensitivity, and some papers are also there which is shown that your specific IgE by specific IgG4 levels may act as better predictors of late phase responses as seen. So this is the paper where they found that patient who had a higher IgE levels at baseline actually had a greater increase in the IgG4 levels after starting immunotherapy. So pre-treatment IgE levels actually were predictive of higher IgG4 values, but the problem with IgG4 is it did not sustain beyond 3 years after cessation of immunotherapy. So IgG4, although a serum base, is easy to study. Currently, we have, I think, FADIA, the immunocap has a specific IgG4 test available only as a research use currently in Western world. It is not yet available in India. It indicates that the patient has been appropriately challenged with allergen exposure. So, which means that there is a shift from IgE mediated to IgG4 blocking antibody is present. So it is an indicator of appropriate immunotherapy. So early increase in IgG4 indicates that at least you're on the right track. That much we can say for right with the current information. So, but there is poor correlation with symptoms. It is not available routinely. And other than IgG4, there are several immunoglobulin G levels which block the IgE levels. And therefore, it can be other IgG1, IgG2, or IgA also can be a potential biomarker. So, we cannot just rely only on IgG4 sometimes. It can be indicative of compliance rather than therapy. So if somebody is not generating an IgG4 in the initial few months after starting immunotherapy, I think that would be a very good indication to discontinue immunotherapy in such patients based on one or two papers. But then again, this is all just early data. So sometimes when we looked at immunoglobulin G values, there is something called as a functional antibody binding, as in IgE binding activity, which is overall activity of all IgM, IgA, and IgG antibodies. By binding to IgE, they prevent the activity of IgE levels. Therefore, basophil inhibition is also occurring. So this is a much more better tool rather than measuring only IgG4, because here, although it is non-specific measurement of the activity, it does indicate is Ig getting inhibited or not. Here they found in a grass subcutaneous immunotherapy, there was a significant decrease in the functional antibody levels, which increased during the first 3 years of treatment and subsequently also came down. The advantage here would be you do not look at only IgG4, which requires specific testing. Functional antibody levels are possible even using your ELISA based technologies, and these are currently being looked at into how it can come into India. So there are several papers which looked at using grass pollen also, how the IgE fab values and the IgG4 values tend to increase after successful initiation of subcutaneous immunotherapy to grass pollen. So although it is a reproducible and a serum based test, it does have a good correlation with symptom scores, but it is not currently available and there is limited data on how it can predict response to immunotherapy. Coming into now we saw antibodies as a possibility. We look at something that is already being used in the Western labs, research laboratories, something like basophil activation markers. So when it comes to basophil activation test, basophil is the major mediator of allergic inflammation, and for this you need to have a flow cytometry technique wherein you use CD63 or CD203 as a marker on the surface of basophils, and if the basophil is exposed to the antigen or the allergen, the sensitized basophil with its specific IgE level on its surface will degranulate, and the degranulation is picked up by CD63 and CD203. A degranulated or an activated basophil will show up in a different path on the flow cytometry, and this is an indicator of an active challenge. So, how do we know if allergen immunotherapy is working? We can find out by actually exposing the basophils of the patient to the allergen and see the reduction in the activated basophils. So, here pre-immunotherapy we need to have a value, and during immunotherapy you can find out if there is a reduction based because of allergen blocking activity. So because we know that in the early phases the earliest response is because of your mast cells and basophils, it actually acts as a very good tool within the first and second month of allergen immunotherapy, and this does have a sustained reduction up to at least 1 year after stopping immunotherapy. These are predominantly due to your IgG blocking antibodies, and the basophil activity does return back to normal upon removal of the IgG levels. So the problem here is that this is again not yet available in India technique. Basophil activation is a very good surrogate of your in vivo testing or provocation testings, and basophil degranulation as a tool will require flow cytometry, labor intensive, and only available in research laboratories. And both SCIT and SLIT have shown successful inhibition of basophil CD63 and CD203 binding basophils using in several trials with immunotherapy compared to your severe allergic asthma or allergic rhinitis patients who are on placebo therapy. So basophil activation test is a extremely easy test. I mean, it's just a blood-based test. Patient does not have to get exposed to the allergen or reduces the incidence of systemic reactions. But there is a variation of response, technically challenging and currently available only as a research tool. And we need more data to its use. And maybe in the future we should see basophil activation test as an active tool. So can we use in vivo testing as biomarkers? So this is one of the most common questions that even patients ask me. Doctor, I have already had a skin test done before. Can you repeat a skin test to tell if I've improved in test or not? Or if you've done a nasal provocation, can we just repeat a nasal provocation to say if I've improved or not? So let us look at what it says. Allergen provocation can be done in different several methods. You can use an environmental exposure chambers where a group of several patients can be put together and they can undergo testing. This is particularly useful in identifying phase 2 and phase 2 trials for allergen immunotherapy efficacy trials. And nasal provocation or conjunctival provocation tests are useful for inpatient or in clinic assessment of patients. And one other tool that is also looked at is your skin prick test. The problem is these are all usually part of your diagnostic investigations, and whether they can be repeated or not is a big question. I looked at several data and I could find that it does indicate responsiveness in a controlled setting, and it acts as a surrogate marker to the clinical response of immunotherapy. Basically, we are challenging the patient to the suspected allergen and seeing if the patient has had a technically desensitized situation or not. But this is not always true. So what happens is this is not the same as a natural exposure. Sometimes the dose of exposure is different from the natural exposure for the patient. There is a lot of standardization procedure. It is a labor intensive test, and several tests are required. Several studies are still required. The problem with skin tests is they do not correlate with symptom improvement. Although it has been shown with several studies that skin test wheal size goes down upon immunotherapy and can be used as a monitoring tool, it takes 1 to 2 years for the skin test, similar to your specific Ig levels, to come down. So you can probably try it, but you don't have enough data to say that you can stop immunotherapy just because your skin test is negative. So provocation test is useful only for your dose finding studies and can be linked to local and systemic biomarker assessment. But more than provocation test, I think we should probably look at basophil activation test as a better tool. So certain other things that are difficult to measure are currently available only in research settings are your cytokine markers, wherein we are looking at a shift from a Th2 to a Th1 mediated response. So all the cytokines of Th2, if they reduce, or if there is an increase in the Th1 cytokines like interferon gamma or TNF beta, can be used as surrogate markers of successful shift of inflammation. But you need to understand the systemic cytokines may not be representative, and only the local cytokines are better informed at improving our knowledge at desensitization. So this is actually based on a paper where interleukin 4, 5, and 9 and interleukin 13 also were successfully decreased after nasal after immunotherapy upon your nasal challenge testing. And these are all local immune response, not the systemic immune response. So but the problem is there is inconsistent data. It is difficult to measure. You need to have an extensively detailed research laboratories, which is currently a little bit labor and cost intensive, and therefore it is not recommended as a biomarker. So, are there cellular biomarkers? We can monitor what are called as regulatory T cells. Again, these regulatory T cells are difficult to identify and separate from your peripheral blood, and these do tend to increase early in immunotherapy, but they are difficult to measure, and they are currently not recommended. So, can we look at something beyond biomarkers? And can we use that as a tool to monitor allergen immunotherapy? Yes, there are some good papers coming up. This is actually from data from several multi-centric studies. Actually, they come up with something called as a predictive response to immunotherapy score, or the PRIS score, where there are 8 factors looked at: the age of the patient, several groups with several scores are given, clinical features with the coexisting rhinitis or asthma. The more the comorbidities, the lesser the score. The more the duration of onset of disease, the lesser the score. The more the number of antigens and the more the number of allergens exposed, the lesser the score. And they have also included a specific Ig by total Ig ratio of more than zero point 0.2, or in that previous study I told as 0.16, might be useful as a data. And major allergen, if they're high, they're also giving higher score. And using this, they were able to say that the patients who actually belong to pre-score between 220 to 100, those who scored more than 80 actually had the greatest mean symptom score change upon immunotherapy, compared to those patients who are between 40 to 60 had a lesser change in immunotherapy symptom scores, at least. So ultimately, at the end of the day, I think patients are only going to ask you how much are they going to perceive a change, and can we use patient reported tools as something like a biomarker. So current we have data to support that digital biomarkers as patient reported outcomes can be used for monitoring in even randomized control trials, and these have been replicated in daily data, wherein they are monitoring the symptom scores, the asthma daily asthma score using your digital data, and also certain scores which are currently useful as digital biomarkers as monitoring tools, because they are the important indicators of treatment efficacy. And this is not captured by objective markers or clinical assessments. It is purely subjective. But because of the reproducibility of the data, So using digital tools like your Mask Airs, there are certain apps like this, because this is the only app which has a patient-centered care use. And there are something called as Health biomarkers, which can be used for daily monitoring or looking at control, just like your glycemic control. We have daily RBS can be monitored, or we can look at control over many months, like using your HbA1c. Similar to that, we have a daily symptom score, which is a electronic combined symptom and medication score, or an electronic daily asthma control score can be used for daily monitoring, where the patient just has to answer several questions. And this is going to give us a tool as to daily symptom control. And also we're going to look at control over 4 weeks, such as called CARET test, which is control of allergic rhinitis and asthma test, which is a better tool to monitor over a 4-week period of time. So data has shown that the CARET score and your daily symptom scores actually are reproducing with the pollen exposure in Western countries. And they have shown that in polysensitized patients also, they were accurately able to pick up the pollen that they were most likely sensitized based on the daily symptom score measurement. And they could use this as a tool for diagnosis and use and monitoring also. So can it be used in immunotherapy? Yes, there has been a recommendation even by IACI to use these symptom scores on a daily basis and on a monthly basis, to use them. And at a particular period of time, somewhere between 6 months to 12 months, we can follow the score. If there is no change in the score, we can very well stop immunotherapy, because the patient is not having any perceived improvement in symptoms. But if there is continuing to be some improvement, and over a period of completing 3 years, and the patient has shown a significant drop in the symptom score and probably off medications, this is something that we don't have cutoffs, but it is recommended to use these as tools for safely saying, okay, now I can late stopping rule, I can stop immunotherapy in these patients, and use them also subsequently for efficacy follow after completing immunotherapy in these patients. So this is where we are right now. I think these are tools that are readily usable, like your CARET and ECMS scores. This is something that I do on a regular basis for my patients. All of them definitely report their combined symptom and medication score, and I use these to because of the advantages, because of the patient-centered monitoring, accessible and scalable use, because of the high resolution of regular improvement of regular documentation of data. There is good adherence and engagement. It provides a real-world evidence of the actual improvement in symptoms rather than a biomarker. But there is subjectivity and variability. Patients need to be motivated to do this daily, and there's a lot of data overload. There is currently some standardization issues, but you can actually use your symptom scores and visual activation. Just a visual analog scale is also a very good tool as a proper tool to supplementary tool for your immunotherapy decisions, but it cannot be used as a biomarker alone as of right now. So what I do is I also ask certain things, like use certain things like large local reactions, because large local reaction is an indication of an intact Th2 system. If the patient develops a local reaction after application of subcutaneous immunotherapy or sublingual immunotherapy, they develop a reaction. It indicates that they have a Th2 system in place. This reaction eventually goes down with time, and if the reaction goes down, it is an indication of development of tolerance and an eventual shift to Th1 mediated reaction. There is no clinical correlation, but it is a very good marker for patient and physician reassurance in most situations. And we can also use your total nasal symptom scores and your asthma control tests for clinical symptom scores. If there is no change in scores or a plateau in scores from starting within the first 6 months of allergen immunotherapy, we can consider allergen immunotherapy discontinuation as a tool. Maybe this would be a much more useful tool in daily practice right now, instead of wasting 3 years of treatment and then looking down the lane that why there is no improvement. In vivo testing, like provocation testing, can be done, but this is to be done only in specialized centers. You need to take it, it is labor intensive, it takes a lot of time to actually do a provocation test, and this is rarely required, especially if you're planning for discontinuation of immunotherapy. SPT per se, there is no role on its own, but maybe at the end of 2 years or at the end of 3 years, it can be used as a tool only in exceptional cases where the symptoms have not shown much change, but you would like to ensure that the skin prick test data has come down along with a specific IgE, particularly component data. particularly major allergens, if they are dropping, if there is a decrease in the major allergen by at least 50%, I'm a little happy with the immunotherapy duration for these patients. So, in summary, biomarkers are diagnostic and prognostic and predictive. They're excellent tools for allergen immunotherapy decisions, but there are several measurable biomarkers like Ig and IgG4 which are already in use. We need to know that IgG4 is can be repeated maybe after 2 years, but not anytime earlier. There are some promising tools like FAB and basal activation tests coming up in the future. And the serial monitoring of biomarkers is generally not recommended unless until it's or at least sufficient time has passed for us to look at. And there are several factors why these come up, but maybe we'll discuss that a little later. I believe genuinely that biomarkers are the future of patient monitoring, and we should consider them in before, during, and after stopping immunotherapy also. And a combination of all of these are to be used for a decision making, and to not rely on biomarkers solely for treatment decisions is the rule of the day. Thank you.
Thank you, Dr. Karthik. It is always a challenge to make a talk on these investigations and pathophysiology are very difficult, and you've done an excellent job of that. Thank you so much. I have few questions. We'll divide them into two. One section which pertains to your talk, I'll finish it now, and the rest we'll discuss it in the panel. Just as a take-home message, how close is the timing between the biochemical and immunological response to the clinical response following initiation of AIT? And which biomarker is available currently, and how early can it be done? As a take-home.
Yeah, so I think at the end of the day, the decision is still clinical right now. If you want to say that you want to use a biomarker to use as a tool, I would highly recommend the clinical symptom and medication score, a combined symptom and medication score, as an excellent tool to follow up and to use that as a data for showing improvement in response. Yes, there are several measurable biomarkers, like IgE is definitely one. IgG4 is available only as a research use. So this in India, if you want to look at something, I would look at only 2 points. One is measurable biomarkers would be a specific Ig levels maybe after 2 years, and particularly components. If I have done a major component at the beginning of the treatment, I would also like to repeat the major component response at the end of 2 years at least, to especially note that I have challenged them. Yeah.
One more thing, when there is endotype identification, I mean, this was a question which is mine, which I was reading. How close is endotype identification in identifying patients for AIT? Is it of any use?
So, I mean, when we talk about endotype, we're looking at, we're looking at both specific Ig levels and for major and minor antigen determinants, right? So, it is something that we do routinely in our practice because we do not want to leave anything to chance. We in such, especially when we're looking at treatments at 2 years 3 years duration of treatment, we want to have sufficient data to say, yes, I want to start immunotherapy only because I know you have a problem which has data to prove your condition is a major allergen determined issue which has proven response to immunotherapy. So for me, endotyping would be more of using components for labeling patients as diagnosing allergic diseases rather than for predicting allergen immunotherapy. And only for that purpose, I would use it. And that's it.
Thank you. I'll discuss the rest few along with the panel. Thank you, Dr. Karthik. Thank you so much. So with this, we'll go on to our next session. For our next speaker, it is such a pleasure for me to welcome Dr. Soumya Nagarajan, who is an eminent pediatric immunologist and allergist with over 15 years of experience from Bangalore. Madam has extensive work, research, publications, etc., including food allergy, for which she is now the best person to take this talk on oral immunotherapy as a treatment for food allergy, how to go beyond. Over to you, Madam.
Thank you, Dr. Soundarya, for a very kind introduction. Is my screen visible?
Yes, ma'am.
Thank you. Again, at the outset, I would like to thank the IAP National Allergy and Applied Immunology chapter for the excellent web series on the allergen immunotherapy, and Dr. Neeraj for the kind opportunity to speak on a topic which is very close to my heart. So when we talk about allergen immunotherapy for food allergy, let me start off with a case series. We have a 7-year-old boy who was born by, he's of Indian origin. He was born and brought up in the US, and he was recently relocated to Bangalore when he was about 6 years old. He has a typical history of an IG-mediated food allergy, history of eye swelling and breathlessness on exposure to peanut soup at 2 years of age, and he subsequently had a reaction later in life. And he was advised avoidance based on the history and tests corroborating the same with peanut sensitization on the skin prick test and on the component testing. Now that he's growing up, the mother is a little worried that does avoidance continue still to be the mainstay of treatment? Beyond avoidance, can we do something more? Because socially, she's a little worried because accidental exposures have happened a couple of times, and can we help this child? So I would like to thank my colleague Elizabeth Tham for the slide. So generally, the diagnostic algorithm of an IG-mediated reaction, as we all know, the main cornerstone still remains history and physical examination, based upon which we would go ahead to decide whether the history is consistent or convincing, does have it a temporal correlation with the suspected food in question. And based on that, we would think about low likelihood of allergy or not consistent with food allergy at all. Possible likelihood of food allergy or a very strong correlation with the food allergy based on the history. So mainly if it's a low likelihood, we would possibly just reintroduce the food back in the patient's diet. If there is a medium likelihood or a high likelihood, we definitely want to do a skin prick test based on the history, what we would want to do, and component testing if required. So if we are not sure, we go on to do an oral challenge or a provocation testing to confirm the diagnosis of food allergy only if the history is very strongly suggestive, but the tests are equivocal. So what I would like to highlight is that avoidance still remains the mainstay of the IG-mediated food allergies as well as non-IG-mediated food allergies. So beyond avoidance, can we do something more? So the concept of immunotherapy for food allergy is a little different, as we have heard about previous lectures on the allergen immunotherapy mainly for aeroallergens. And how is it different? So mainly, I think the goals of allergen immunotherapy mainly for the aeroallergens and food allergies, basically we are looking to desensitize for aeroallergens, and we know that it works very well. But in food immunotherapy, the initial thing is to reduce the actual threshold of the reaction of the patient, even if the patient is exposed to that particular food and does not have a anaphylaxis. So that is the main goal of immunotherapy. Initially, the aspect was mainly only on oral immunotherapy. I think there are emerging concepts about sublingual immunotherapy for the management of food allergies as well as epicutaneous immunotherapy, which I will be discussing very briefly in my subsequent slides after oral immunotherapy. So I think in the long term, I think even they are studying oral immunotherapy, can we induce a level of immune tolerance or desensitization even in food allergies or something called sustained unresponsiveness. So right now, the goal of immunotherapy in the context of food allergies, especially when we are talking about oral immunotherapy because we have more data on this modality of immunotherapy for food allergies. Right now, it is mainly to induce the threshold level for the patient clinical reactivity and possibly sustained unresponsiveness in the near future. So, before going on to the actual oral immunotherapy, we have to understand that the mechanisms of by which how an oral immunotherapy induces the increased thresholdness and possibly sustained unresponsiveness in the long term is a little still ambiguous. But couple of papers have highlighted that the gut microbiota has been shown to interact the mucosal immune system at many levels. Okay, so mainly it is inducing IL-1 beta, mainly on the from the antigen presenting cell, where it influences the dendritic cells by inducing the Treg or the B regulatory cells to produce certain short chain fatty acids and other immunomodulators, which could in the long term be helpful for adaptive tolerance. Again, we were talking about remission or sustained unresponsiveness in the context of oral immunotherapy. So basically, the cells involved in the desensitization, remission, or tolerance in the long term, there are a lot of overlaps between these states, and mast cells and basophils definitely play a major role in the desensitization part. So direct in vivo evidence have demonstrated, especially in the murine models, that the Treg, Breg cells, especially in the production of IL-10, tryptophan, and retinoic acid metabolisms and short-chain fatty acids, which play a major role in the long-term remission or tolerance to patients with food allergies. So before we go on to understand the background of oral immunotherapy, I think there are 2 or 3 terminologies we should be very familiar. So oral immunotherapy, we are actually giving the patients that particular allergen to which the patient is allergic to in a non-processed form or in an oral preparation. There is no commercially available preparation except for palforzia or the peanut preparation, which I will highlight it briefly in my later slide. Otherwise, it is usually in the non-processed form we use it. Desensitization is the ability to consume that particular food, which has been the triggering factor during the progression of the oral immunotherapy without major adverse reactions. Okay, so that is the first goal point of the immunotherapy in food allergies. Sustained and responsiveness, even after we stop oral immunotherapy and the patient continues to take that food, he or she should not have any reactions when the patient is exposed to that particular trigger allergen. And tolerance, indefinitely the patient can consume these foods without any issues at all long time after stopping oral immunotherapy at all. So the primary endpoint, we always look at desensitization in oral immunotherapy. Possibly the studies are ongoing or reporting that sustained unresponsiveness is there even after you stop oral immunotherapy for a period of few years, though tolerance is being studied and we are awaiting results for the same. I think in the recent past, most of the world allergy organizations in their guidelines on food allergies, including the Gallon Food Allergy Guideline Groups, which has incorporated, and the Yaki position paper on the IG-mediated food allergies, which was published last year, has been, no doubt the avoidance remains the mainstay of treatment, but they also have recommended, included oral immunotherapy for patients with food allergies more than 4 years. And this age group is coming down with more ongoing studies and recent couple of papers published in which were presented in Quad AI earlier this year and published subsequently in JACI, they have said that even oral immunotherapy could be, immunotherapy, not oral immunotherapy, immunotherapy for food allergies could be as started early as 1.5 years of age. And probably they were only thinking about sublingual immunotherapy, which is in a very, very early stages. So right now, the guidelines say that oral immunotherapy is recommended for 4 years and above for severe allergies, with a strong emphasis on the peanut immunotherapy because more studies are there. Epicutaneous immunotherapy, which will be dealt upon the mechanism of action by Dr. Neeraj in the subsequent talk, also finds a place in the food allergy immunotherapy guidelines as well. So, hands down, my take-home message for all of us is oral immunotherapy has to be considered in patients where the possibility of the social stigma is more. The chances of the accidental exposure causing life-threatening anaphylaxis reaction is more, which is substantiated by the previous serious life-threatening reactions and component testing, which shows that the possibility of the patient outgrowing these food allergies are less and will be persisting for probably a longer period of time. I think we have to take it all into consideration and then think about the immunotherapy for food allergies, because the cofactors are many. And during the subsequent journey of immunotherapy, probably I would be talking more about oral immunotherapy because it would have come with its own shares of gastrointestinal adverse events, which is a major limiting factor also for the patient. And we have to be supportive for these patients, and they would have to have manage their cofactors such as exercise or infections and other illnesses, making sure that the asthma is under control. We have to have this discussion with the patients and then go on to decide about embarking on the journey of immunotherapy for food allergies. It is not as easy as we do desensitization for aeroallergens. So I think bearing into all these factors, we should go ahead. So oral immunotherapy, basically, we are involving the daily ingestion of food allergens with increasing doses, mainly under supervision, every month, generally about every 2 to 4 weeks, until we hit the maintenance goal. Basically, there is strong evidence that OIT has successful desensitization. That means the patient can continue taking this food during the course of oral immunotherapy. By the end of oral immunotherapy, the desensitization rate is very good, close to up to 80% and more. So, and this right now, the guidelines definitely say 4 years above. Initially, we used to think about 5 to 6 years and above because the patient could vocalize. And right now, the guidelines recommend 4 years above. And definitely, it is indicated only for IgE-mediated food allergies presently. And the peanut OIT received, the product received FDA approval in 2020, which is Palforzia. So OIT comes with its own pros and limitations. I think right now we have very strong evidence for food allergy specific treatment, and it definitely increases the threshold of the allergen reactivity even from very initial stages. Even on accidental exposures, the patient could have very minimal reactions, and desensitization up to 80% is definitely achieved. And sometimes if we have a cofactor which is not allowing us to step up, we do add on omalizumab as an adjuvant to the oral immunotherapy in patients who are undergoing oral immunotherapy. But when the patients are taking oral immunotherapy, they continue to avoid that particular food in their diet. So the down factors also include, because there is lack of standardization except for peanut, and the adherence is a little tricky issue sometimes if there is a gastrointestinal side effects such as non-specific throat itching, abdominal pain, nausea. So I think this also adds on to their quality of life issues and lack of biomarkers presently. So basically, when we are doing an oral immunotherapy, we initially try to, where they have an allergy, we do a baseline oral food challenge. We know that the patient is going to react, but at what threshold is the patient going to react is the main determining factor, depending on which we decide whether at what point we are going to start the oral immunotherapy, what milligram of protein of that particular food we are going to start. So initially, we increase a very, very small incremental doses of the initial build-up phase at to a certain point, which may take about few months, generally about 4 to 6 months. And after that, if the patient is doing well, we may probably increase it every 2 to 4 weeks, depending on the patient capability of tolerating. And I haven't done weekly, probably bi-weekly, it may be a little too early. 2 to 4 weeks, we would try to do the build-up phase, and they would continue to take the maintenance phase. At a certain point, probably about 12 months to 18 months after the embarking on the oral immunotherapy, we stop the OIT and the patient continues to eliminate, and then we do a oral food challenge after a short period of abstinence of that particular food. And depending on if the patient is able to tolerate the food challenge, it induces tolerance. So this is a little tricky issue where we may not be able to achieve in most of the clinical scenario, but the desensitization goal definitely is achieved. After stopping oral immunotherapy, we may not ask them to take it the standard dose. We may tell them to what was the last meal portion they were having, to continue to take that every 2 to 3 weeks once in their diet. So definitely, I think we have desensitization begins within few days to maximum few months after the treatment. And even if the patient has had an accidental exposure, they wouldn't be able to have major reactions, especially younger children, where in the school or when they're having play dates. If the children unknowingly come in contact with these particular allergens, the chances of accidental reactions also goes down. And yes, primarily, I think it's the gastrointestinal symptoms, and viral infections or exercise also are the other cofactors sometimes, are a major cofactors which has a hindrance on stepping up the dosing in the oral immunotherapy. Tolerance, we definitely have not seen in the blinded studies, though follow-up studies have been ongoing. I think the major risk factors for unanticipated reactions include the infections, hormonal changes, exercises, and symptoms occur in the initial quarter of the updosing. Predominantly, it is mild and oropharyngeal or gastrointestinal. There are very less doses which are moderate to severe, which has developed anaphylaxis, and we had to give epinephrine even in the data. And gastrointestinal symptoms also contribute to the dropout from the oral immunotherapy for food allergies. So Palforzia is the which was approved by the FDA following a very strong phase 3 clinical trial, and it is recommended, approved for treatment of peanut allergic patients, IgE mediated peanut allergies from the age group of 14 to 17 years. And initial dosing is done in the healthcare setting. After that, they usually continue to take the updosing with frequent follow-ups. And again, it should be avoided. Peanut exposure should be avoided while taking Palforzia. Caveat that it does not cure peanut allergies, but definitely reduces the risk of allergic reactions even after accidental exposure of peanut. So coming to sublingual immunotherapy, I had the fortune of visiting the clinic of Dr. Vinay Mehta earlier this year, and sublingual immunotherapy is what is not yet find its place in the clinical guideline, but I'm sure with the ongoing studies, we would see this recommendation probably to be looked out for in the next few years. Basically, sublingual immunotherapy, where the children or the patients who have had major gastrointestinal manifestations in the initial updosing, where we cannot step up the dosing during oral immunotherapy, this would allow to minimize the gastrointestinal side effects, but also possibly increase the dosage of initial few doses of the milligram protein of that particular food, and then switch over to oral immunotherapy. So they are not looking at mainly the long-term effects of sublingual immunotherapy yet, though I think that is the long-term plan. But this is being used as a bridging course for the patients to get over the gastrointestinal manifestations, and then they're graduated to the oral immunotherapy. Sometimes if they have aversion to the taste, in order to mask the taste, or it's sublingual because it is put under the tongue. So this is used as a mainly for the bridging for the patients to graduate to the oral immunotherapy. Here, they found that one of the studies for good 48 months found that the milder reaction was mainly limited to the oropharynx, the gastrointestinal, the more abdominal pain, nausea, all that definitely was very less, and it was self-limiting. So I think this is a very promising tool, but long-term studies are required for it to be validated in the guidelines. Coming to the epicutaneous immunotherapy, where we are talking about the gastrointestinal manifestations being the major limiting factor for the patients to continue in about 20% of the patients, this helps relieve the those adverse events, where mainly the allergen is put in the patch, proprietary patch, which is put on the skin of the patient, and this is used daily. So I think the more evidence is in peanut, mainly phase 2 and phase 3. This is in context of food allergies, and they found that where they were phase 3 trial, patient allergic between 1 to 3 years of age were recruited in the study, and after epicutaneous immunotherapy for 12 months, they found that 67% of the patient met their primary endpoint, where they should be able to tolerate either 300 or 1000 milligram of peanut based on their baseline reactivity, which is quite remarkable, at least close to 70% of the patient. And mainly the adverse reactions were mainly mild, 99%, and it could be probably large local reactions, and which were self-limiting. About 7% of patients who were on epicutaneous immunotherapy did report anaphylaxis. So this was one of the studies which was published in JAMA in 2019, and this was this had showed that the peanut patch was definitely more effective than the placebo. So I think when we are comparing epicutaneous immunotherapy as versus oral immunotherapy, the more studies are towards oral immunotherapy, but epicutaneous immunotherapy is definitely more interesting because it definitely does reduce the systemic side effects of the oral immunotherapy. And I think this is an interesting aspect to look out for also in the management of food allergies in the near future. So we did present our data on oral immunotherapy, and basically we did the main food allergens were peanut, we did, and the adverse effects of oral immunotherapy were mainly gastrointestinal, as I was highlighting earlier. And the major limiting factors for predictors for adverse reactions in our cohort was previous severe reactions, anaphylaxis, and asthma, and baseline increased AAC. Cofactors included infections, exercise, menses, and sometimes we had to take care of the cofactors and continue immunotherapy, but we had to discontinue OIT in few of them because of the gastrointestinal manifestations. So again, thank you for a very patient hearing.
Thank you so much, ma'am, for that lovely, concise talk of such an extensive topic. Thank you so very much. Ma'am, before I move on to the next talk, just two questions. Ma'am, can you comment on the risk of eosinophilic esophagitis, which comes up in many of these oral immunotherapy side effects?
That is a theoretical risk factor for patient who can develop during the course of oral immunotherapy. Most of the major the trials, they have shown that probably less than 1% of the patients who underwent oral immunotherapy had eosinophilic esophagitis. The conclusion is not very strong that whether they did have EOE prior to the initiation of OIT, or was it as a cofactor or possibly a endpoint after OIT. I think in our patients in my cohort of patients who underwent oral immunotherapy, one patient had during the course of OIT. So the conclusion is not very strong, but yes, they say that the possibility of EOE could be there in patients less than 1% who undergo OIT.
Is it possible that this EOE got unmasked? Means it was there and
probably even
OIT kind of.
Yeah, even I feel that, because OIT definitely induces more gastrointestinal manifestations because of the basic pathophysiology which happens during the course of OIT. Possibly, I think the hypothesis is the same. It may have been there earlier because there is no diagnostic test, or we may not have had gone through more detailed workup for EOE in these patients.
One more, in case of these severe reactions, is it advisable to withhold OIT, or do you advise that in severe children who are really allergic, what is the role of adding omalizumab and kind of trying to reduce the reaction going ahead? Which would you think is a better option?
I think starting OIT per se is a major milestone for these families and children who are having food allergies. I think when we have embarked on this, I think when we add on omalizumab, definitely we would be able to overcome cofactors. And I have had very good results when we have add on omalizumab to patients with OIT, and we have been able to come to that primary endpoint also. So it's an excellent add-on. For patients.
Thank you, ma'am. Thank you. Thank you so very much, ma'am. So
Thank you.
now as we move forward, now let us go to the third session. The third session is by Dr. Neeraj Gupta. Dr. Neeraj Gupta needs less introduction, and I think Sir is known all over. Sir is the chairperson of the Indian Academy of Pediatric Allergy and Applied Immunology chapter of our country. Sir has innumerable publications to my name. He is my mentor, my teacher, and with this, I have to ask Sir to go further. I'm looking forward to listening to him along with all of you. Over to you, Sir.
Thank you, Dr. Sundarya. I must admit that I think Dr. Karthik and Dr. Soumya both have really stolen the show of the day, and the fantastic presentation, clinically relevant presentation, which I have heard, I was really highly impressed and learned a lot by the previous two presentations. So my presentation is more towards a futuristic view and what we can look forward in the future, or I will say that in the near future, probably another 2, 3, or 4 years down the line. So the topic today is beyond needles, emerging routes like intralymphatic immunotherapy and epicutaneous immunotherapy. Just in brief about history of allergen immunotherapy, we understood that the art of this subject allergy is somewhere around 200 years old, in which initially it started somewhere in 1820, and somewhere in middle there were some landmarks which happened. Among these landmarks about allergen immunotherapy, the first breakthrough happened somewhere in 1900s, in which Dr. Noon started vaccination against aerogenic toxins. And after around 50 years or so, then the second landmark event which happened, in which Dr. Franklin first started the formal skit trials. And thereafter, the discovery of IgE by Ishijaka Payer. And then somewhere in 1990s, the sublingual immunotherapy which came up into picture, and the official trials which started with the sublingual immunotherapy. So till date, what we understand that the subcutaneous and sublingual, these are the two predominant allergen immunotherapies which we are hearing. Dr. Soumya has also mentioned about oral immunotherapy, and the trials about oral immunotherapy, they are not very, you can say, like I will say that very long or very past. It is a very recent type of trial which have happened in past few years. So just to once again recapitulate and making the context, how everything starts. So we understand that allergens, when they come in contact with the antigen presenting cell, they could be your dendritic cells or the Langerhans cells, and then they are presented to the CD4 naive cell. And in an atopic individual with the favorable environment, then at that particular time, the interleukin 4 is released. And here, the CD4 naive T cell is getting converted towards a pathway of Th2, and then ultimately all other interleukins are released, and then several different mediators, different cells which are coming into picture, and ultimately they are creating allergic manifestations. Now, how allergen immunotherapy acts? So we have already spoken a lot about allergen immunotherapy. So what it does is that it acts on this very crucial step that the CD4 naive T cell is not able to convert to Th2 cell. It is basically converted to T regulatory cell. And when it is converted to T regulatory cell, in the presence of so many other environmental stimuli, and ultimately there are different set of interleukins which are increased, like IL-10, IL-35, TGF-beta, and ultimately all these, you can say, like lead to a more immune tolerance type of a mechanism. So this allergen-specific immunotherapy, whether it is subcutaneous immunotherapy or sublingual immunotherapy or probably oral immunotherapy, which we have spoken about. So this is having different function on the different cells of the immune system. So on the T cell, it actually reduces the Th2 cytokines, increases the T regulatory cells, and also increases the P regulatory cells. It simultaneously also increases certain interleukins, which are favorable interleukins like IL-10, IL-35, and TGF-beta. When it is acting on B cells, then at that time, the IgE levels are reduced. Dr. Karthik has beautifully enumerated about reduction in specific IgE after a certain time, and then increase in IgG4 and B regulatory cell also increase. On the dendritic cell, the MHC class 2 histocompatibility protein they reduces, and then certain CD factors they reduce, and once again IL-10 and TGF-beta increase. And then when it is also acting on the basophils, eosinophils, and mast cell, and ultimately their activation threshold increases, their activation decreases, and inflammatory mediator release reduces. And all this actually translates into the clinical outcome, which is medication requirement is reduced, allergy symptoms are reduced, allergen reactivity is reduced, and life quality actually improves. So the conventional existing allergen immunotherapy, whatever we have spoken over past 1 week or 8 days, that is subcutaneous immunotherapy, has got so many advantages. It is having proven efficacy and safety. There are n number of studies. We need not to once again rewrite the science. It is absolutely fantastic, with possible applications in venom immunotherapy, fantastic applications, I would say, increased efficacy in head-to-head comparison to so many trials are there. Coming to sublingual immunotherapy, proven efficacy and safety, there are no injections, usually preferred by the children, less dependency for healthcare unit, and potential for home application. And that is why now this sublingual immunotherapy is considered to be the talk of the town. And the people are now moving, the world is now moving from subcutaneous immunotherapy towards sublingual immunotherapy. And this oral immunotherapy, I think a beautiful presentation by Dr. Soumya, proven efficacy for sustained unresponsiveness or bite safe, or I will say desensitization, and potential curative treatment for food allergies. But there are certain limitations also with the existing modalities. First limitation is long-term treatment. So we all understand that whenever we will speaking about SCIT, SLIT, or OIT, we are always talking about months and years. So here it comes the need for frequent clinic visits. And when it comes to frequent clinic visits, then at that time the compliance reduces. Then the compliance reduces, the patient adherence becomes poor, and it is much more poorer in case of children. And nowadays, even there is a migratory population. The people from one state are going to another state for some work, for some studies, or even for, you can say, like taking a consultation. So it becomes actually very difficult for them to frequently visit for a longer time. And then the limited allergen dose delivery, which is also a big problem, and then risk of systemic reactions. I think my previous co-speakers were already speaking about the risk of anaphylaxis, severe reaction, though whatsoever percentages they were there, but yes, they exist. And then suboptimal efficacy in some patients, like Dr. Karthik mentioned about that the same dose, same everything, but some patients are responding and some patients are not responding that beautifully. So these are some limitations. So can we do something here? So yes. So there are newer developments which are now happening in the field of allergen immunotherapy. And these newer developments are, first of all, can we present the allergen, the I will say the allergen to immune system, to the lymphoid organ in a different manner. Ultimately, whatsoever you are using, whether you are using SCIT, you are using SLIT, you are using OIT, everything you are actually based upon presenting the allergen by different routes, by different mechanisms to the lymphoid organs, to the lymphoid tissues. So can we do something different? Can we use a different novel route? Can we use some biomarkers to do predict? Dr. Karthik has already beautifully highlighted about that. Can we use some adjuvants or can we use some allergoid? So allergoid is something which can actually retain the immunogenicity but reduced allergenicity. So here comes the role of novel routes. So the novel routes for allergen immunotherapy, these are the two novel routes which I'm going to speak today and which, to my understanding, seems to be the next trend or the next future. In next 4 or 5 years, we'll be having more and more papers and more data from it. So one is intralymphatic immunotherapy, another is epicutaneous immunotherapy. What is intralymphatic immunotherapy? As the name suggests, that we are now directly entering into the lymph node. We are, you can say, like directly going in the home of the lymph system. So rather than just relying on the peripheral lymphatic system, we are actually entering inside the lymph node. So this reduces the number of injections. This also reduces the amount of the allergen dose which is injected, and it also reduces the treatment duration. Whereas epicutaneous immunotherapy, we are not entering anywhere. We are just going epicutaneously. I will be discussing about that later on. And it also reduces the treatment duration. There is no needle involved, and it is having a good safety profile. So let's talk first about intralymphatic immunotherapy. It is an emerging allergen immunotherapy technique in which small doses of allergen are directly injected into the lymph node under ultrasound guidance. So these small doses are much smaller. Like when Dr. Somya was speaking, she was speaking about some milligrams. When we are talking about subcutaneous immunotherapy, we are always talking about certain milligrams. In sublingual immunotherapy, talking about milligrams. But whenever we are talking about this intralymphatic immunotherapy, we are actually talking about micrograms. So these are such small doses of allergens which we are talking about. And targeted delivery enhances immune tolerance efficiently, allowing for faster symptom relief because we are directly targeting the immune lymph node, which is, you can say, ultimately the target organ. So we can definitely hope for a faster relief, and actually practically reduces the entire duration which Dr. Karthik was mentioning, at least 3 years. I am saying somewhere around 3 months only. So 8 to 12 weeks is the right time for only 3 injections in the lymph node. Job is done. That's all. So let's see what is happening here. So if you just see on the left-hand side of your screen, so this is intralymphatic immunotherapy as compared to subcutaneous immunotherapy. In the subcutaneous immunotherapy, we are talking about years, whereas in intralymphatic immunotherapy, we are just actually talking about probably a few weeks only, and we are reducing much lesser dose in intralymphatic immunotherapy. Now, when we are talking about subcutaneous immunotherapy, then at that time, what we are doing? We are not going in the lymph node. It is an extra lymph node injection. Just see that the needle is somewhere which is not reaching to the lymph node. It is extra lymph node injection. So there is a possibility that all the mast cells are there lying within the dermis and all those areas. And these mast cells, when the allergen is going directly there, then they can produce some allergic reactions, and adverse reactions are there. And that is why the subcutaneous immunotherapy is having more chances, increased chances of allergic reactions. Whereas if we are directly entering in the lymph node by carefully locating the lymph node exactly at the cortical area by ultrasound guidance, then this is called as intralymphatic immunotherapy. So we are not directly going to the mast cell, and ultimately the allergic reactions or the adverse reactions are reduced. So actually accuracy defines the efficacy and the safety. So we need to be, you can say, like dot accurate looking at the ultrasound, and then thereafter. So this is the area, like if you just see that the lymph node area in which there is a medulla, then there are certain follicles, and then outside the medulla, there is a cortex. So cortex is the right area which needs to be delivered. So the lymph node with a thick cortex is the ideal lymph node, and we need to really avoid all the other structures which are coming in between. So this is the technique. This is from our hospital. I have just taken today only, this picture, the lymph node needle, so in which the inguinal lymph node is located by the ultrasound, and then this needle is going, and you can just see that my cursor, if you can just see, so I'm just, you can say like encircling the lymph node. So this is the lymph node which is encircled, which I'm encircling, and then this, you can say like the less, you can say like more whitish area, I will say echoic area, which is there, which is the cortex area, and more darker area, which is hypoechoic area, is the medullary area. So we need to really, you can say like locate the cortex here, and then we need to go with the, you can say like intralymphatic immunotherapy. So let's talk about certain studies. So about the clinical efficacy. So intralymphatic immunotherapy can actually alleviate allergic symptoms, which are seen in the daily life. So this is just like a baseline symptom for the VAS score. If you just see the rhinorrhea, sneezing, itchy eyes, itchy nose, nasal obstruction, and postnasal drip in selected patients, which have been given with different type of immunotherapy by ILT. So ILT, so in which it is like dog, dust mite, dog, cat, dust mite, all these patients, these are the number of patients. And if we just see the symptomatic improvement, so at the start of the baseline, the symptoms were like this, the first dot, and thereafter, like at 4 months. So immunotherapy was finished within 3 months' time, 8 to 12 weeks. But later on, when these patients were followed up till 1 year, so the symptom reduction was definitely there. If you can just see, all the symptomatic reduction were there, and this is the statistically significant p-value. Though the sample size is limited, but still all the symptom manifestation, even after stopping immunotherapy, it is really good. Then the question is that if somebody who is treating with a monoallergen immunotherapy or polyallergen immunotherapy, so this is one paper which has been published in 2022 with intralymphatic immunotherapy with 1 or 2 allergens renders similar clinical response in allergic rhinitis. So if you just see that the first cohort on the left-hand side panel, there's a birch pollen plus 5 grass pollens. They were combined together, and ultimately they have been given intralymphatic immunotherapy. In the second one, the second panel, only the birch pollen along with placebo, and in the third one, the 5 grass pollens along with placebo, they have been given. And if you just see the quality of life, if you just see the symptom score, medication score, so all are having, you can say like nearly similar type of efficacy, and it has been seen that whether it is a mono therapy or a polytherapy, both are responding. But if you want to compare head to head, then monotherapy is much more better responding as compared to polytherapy. Then coming to efficacy by lab parameters like biomarkers. So if you, once again, the needle is there in the cortical area of the lymph node. So this is the cortical area of the lymph node, which I was mentioning, paracortex or the cortical area, and this is the medulla, where you are actually supposed to inject in the lymph node. And if you just see that the obvious parameters of lymph node swelling, so when it starts acting, it actually starts acting within hours. So when you start acting like you see on day 0, within hours, and you see the lymph node swelling, whether the lymph node is swelling or not. So yes, it starts swelling. Then on day 14 and day 28, when you are following the injections, and then every 2 weekly, and then you are seeing or looking at what is happening. Similarly, the IgE levels, similarly the IgG1 and IgG4. So if you just see that IgE levels were either similar in the follow-up or they were a little increased, but IgG1 and IgG4, they both were increased. And then what they have also done is that they have done the bee sting challenge. So in the bee sting challenge, what they have done is that to start with, when they wanted to start intralymphatic immunotherapy, before that, they did the bee sting challenge in these patients, which was obviously positive. And then later on, after intralymphatic immunotherapy, they once again did the bee sting challenge. And the procedure for bee sting challenge was that they have just taken, you can say like a bee or honey bee inside the syringe. And they, as you can see in the figure, and they have put it on the skin. And then they have tried to press the plunger. So that means they have really pushed the bee sting, pushed the bee to sting the person. And then the stinger was there, which was left for around 24 hours for that particular time, just to remain effective, both at the start of the study and after completion of intralymphatic immunotherapy. And what they have found that the bee sting challenge score was significantly lower after completion of 3 injections of intralymphatic immunotherapy as compared to the baseline. So this seems to be definitely efficacious, there is no doubt. Now, this is a short-term efficacy. What is about long-term efficacy? So this is a 5-year open label follow-up of randomized controlled trial in which they have seen that intralymphatic immunotherapy for birch and grass allergy that reveals a long-term beneficial effects. So if you just see that this is like for the birch and the grass pollen, and the first figure is for the combined symptom and medication score. second one is for the symptom score, and third one is the medication score. So if they have seen that in all these cases, the active immunotherapy group, they have actually got, you can say, like a better symptom score or medication score. And even in the medication score, it is definitely clinically significant with a significant p-value, which was there. So it's a long-term commitment to the long-term efficacy is definitely there. Now, this is another study which is for a 19-year follow-up study in which they have seen for the quality of life in a long term. What they have seen is that in this trial, they originally recruited in 2002. In 2002 to 2005, they took around 112 patients, out of which they have randomized them equally to 58 patients in intralymphatic immunotherapy group and 54 patients in subcutaneous immunotherapy group. And then thereafter, means like they tried to follow them up after completion of the treatment, and they were able to follow up nearly 23 and 27 patients in this group. And simultaneously, they also recruited another cohort of patients who have received subcutaneous immunotherapy in between 2015 to 2018. And there they were able to follow up this cohort of patients for few years. Around 18 patients were followed up. So if you just see the symptoms, so the symptoms like the quality of life scores, the symptoms of the nose or the eye or the emotional symptoms of the activity scores. So if you just see the symptoms of the off-season symptoms, so in the intralymphatic group, the off-season symptoms were definitely lesser in the follow-up of 19 years as compared to subcutaneous immunotherapy group. So this was definitely there. Now this subcutaneous immunotherapy group is that group which was recruited in 2002 to 2005 along with the intralymphatic immunotherapy group. That means after 19 years of both the therapies, vis-a-vis when you are comparing, the intralymphatic immunotherapy seems to be having a much prolonged efficacy as compared to subcutaneous immunotherapy. Whereas if you just see the other symptom scores and combining all the three groups, that means intralymphatic immunotherapy, subcutaneous immunotherapy for 19 years, and those people who have received subcutaneous immunotherapy recently, that means in 2015 to 18. And ultimately what they have found that once again, intralymphatic immunotherapy group was definitely having a statistically significantly better efficacy as compared to the rest of the two groups. What are the adverse effects? Let's see, because we have seen that in the subcutaneous immunotherapy, there are, you can say like the allergen can go directly to the mast cell, and ultimately it can actually produce certain adverse effects. But what is happening with the intralymphatic immunotherapy? Is there any adverse effect? Let's see. So this paper is suggesting about the house dust mite, cat, and dog allergies with the adverse effect. So majority of the time, there is no adverse effect. But sometimes there are mild adverse effects which have been seen in certain patients, like some itching or urticaria, or one patient complained of diarrhea or urticaria, which is there. Only 4 patients which have actually shown these adverse effects. So 4 doses among nearly around 36, 37 doses, the patient has shown this adverse effect. But there are 2 times anaphylactic reactions have also been noticed with these particular patients. So this we need to take care about that. So the advantages of intralymphatic immunotherapy is it is a shorter treatment duration, only 3 to 4 injections over 8 to 12 weeks, and that's all, you are done. Rapid onset of clinical benefits, even the benefits are visible within weeks or probably 1 or 2 months only. Whereas if with the conventional immunotherapy, we usually say that the clinical benefits are usually available in 9 to 12 months. Reduced allergen dose requirement only in microgram as compared to the conventional doses in milligram. Fewer hospital clinical visits, only 3 to 4 visits, because you just require that injection. Potentially better patient compliance. That means because you have just got, you can say like only few visits, so short duration, few visits, fixed schedule, so more better patient compliance. And then targeted immune activation. So you are actually targeting the lymph node, and there the lymph node is directly getting, you can say like converted to the Treg. The immune system is directly getting shifted towards the Treg. So it's a more balanced Th1 Treg immune system response as compared to SCIT, where some of the you can say like allergen is actually getting directly to the mast cell, producing some Th2 type of pathway reaction, and some other is reaching to the lymph node, producing a Th1. Here you are actually delivering everything to the lymph node. So ultimately, it is more balanced Th1 or T regulatory immune response, and lower risk of systemic reactions as compared to SCIT or oral immunotherapy, and it definitely produces improved quality of life. But there are certain limitations also. So definitely it will require an ultrasound guidance. Definitely it will actually require, you can say like some skills, and then only you can give. So you cannot do it in your clinic. You cannot do it in your, you can say like probably like that freely. So you actually require some expertise for that. And then the children might have some needle phobia. Even adults might also have some needle phobia. Though it is painless, it is considered to be painless. Reason behind, because when you are entering, then at that time, these entering the skin and the lymph node. So lymph node itself is considered to be painless. And when you are entering through the skin and the lymph nodes are just lying very superficial in the inguinal area, so that superficial area of the skin is also not having that much pain fibers. So it is considered to be painless technique, but still the needle phobia can be there and the parental child concern can be there. And the other problem is that still there is a risk of side effect, because it is possible that you are trying to inject it in the lymph node, but sometimes because of the limited vision with the ultrasound or with your technique, or sometimes if your hand is getting, you can say like disturbed while doing the technique, then at that time the leakage of allergen can happen from the injected lymph node, and that can actually spill the allergen to the surrounding mast cell, and then the risk of the side effects can happen in this intralymphatic immunotherapy. So this is one part. Now I will be moving to the second part, which is epicutaneous immunotherapy. As the name suggests, epicutaneous immunotherapy is aimed at promoting the passage of large proteins and or allergens into the first layers of epidermis, which are rich in pre-tolerogenic Langerhans cells. Now here, this is a very, very contrasting type of a story. Like whenever we are talking about dual allergen hypothesis, whenever we are talking about skin is a, or the skin exposure is, you can say like considered to be immunogenic, allergenic, whereas the oral exposure is continues to be tolerogenic. So on the one hand, we are saying that whenever an allergen is coming to the skin, then at that time it is producing allergy. It is producing Th2 pathway. And here in epicutaneous immunotherapy, I am saying to you that when you are applying allergen to the skin, then at that time it is tolerogenic. So how these two things are going side by side, we will be discussing about this in a minute. So the important thing here is that the targeting the highly immunocompetent area allows for the application of microgram amounts of allergen. We just require only microgram of allergen. No milligrams are required or grams are required. So epicutaneous immunotherapy is not a new technique. It has been first documented around 100 years back by Dr. Redot and his colleague for environmental allergies. So what they have done, the method involved repeated cutaneous reactions, essentially applying allergens. They have taken the horse allergen and they have applied it to the scarified skin to induce desensitization. And they were able to reduce systemic allergic manifestations. Predominantly, they use it for asthmatic manifestations. Then the next use, which have been described in the literature, is in France, somewhere in 1960s, and they employed a technique called quadrille ruling. What is that? That means that creating a tiny grid-like scarifications on the skin before applying pollen extracts. It was used to treat pollinosis or hay fever with reported success compared to skit. But thereafter, the literature is very silent about epicutaneous immunotherapy, and it has been the recent past only that it is once again researched. So let's now understand the concept behind epicutaneous immunotherapy. So as I was mentioning about the dual allergen hypothesis. So what is happening in the dual allergen hypothesis, that when the allergen is coming in contact to the inflamed skin, in contact to the broken skin, in contact to the defective skin, then at that particular time, this inflamed or defective or broken skin actually behaves like allergenic, immunogenic. So when it takes the allergen, then it stimulates the Th2 pathway. Whereas whenever we are doing epicutaneous immunotherapy, it has to be a non-inflamed skin. It has to be an intact skin. It has to be a normal skin, which is really very important. So like in this figure, if you just see that the non-inflamed skin, here, these are the superficial layers of the skin. The first superficial layer is the stratum corneum, then there is epidermis, and then goes the dermis. So we understand that the lymph nodes are usually there in the dermis, and then in the stratum corneum, when the allergen is applied on the skin, that means on the stratum corneum, then these Langerhans cells, which are the antigen presenting cell, they are predominantly present in the epidermis, and they are having their dendrites. So few of the dendrites are, you can say like expanding their legs in the stratum corneum. Means they are sampling the stratum corneum for the environmental stimuli. And once in the environment, they are getting that particular allergen. So this particular dendrite will take that allergen. This is an antigen presenting cell. This will take this particular allergen, and now it is a non-inflamed skin. And in a non-inflamed skin, actually what happens is the increased expression of PDL2, and simultaneously there is a slight increase in the expression of CCR7 and MHC2. And ultimately, this Langerhans cell is now getting shifted inside, and then it is presenting this allergen to the lymph node. And when the CCR7 is increased in limited quantity, then it helps guidance of this migration. And ultimately, in the lymph node, this allergen is present into, you can say, like Th naive cell, T naive cell, and which is creating the T regulatory response. How this is happening, let's see. So this is a large view of the same thing, in which now the allergen has reached, the Langerhans cell has brought the allergen inside, and then the allergen has reached here inside the lymph node. And now this allergen is presenting this APC, or the Langerhans cell is presenting this allergen to the Th naive cell. And here in the lymph node, now there are certain, you can say, like positive factors or the tolerogenic factors which are produced, which is FOXP3 and then LAP plus. All these factors are produced, and ultimately they help in converting the T naive cell response to T regulatory cell. And this T regulatory cell actually then increases the other, you can say, like factors like CCR3, 8, and CXCR3, and they ultimately are responsible for long-term maintenance and long-term decrease of Th2 response. And then they are also having the systemic effect. So like allergy is having, like in atopic march, allergy is having a systemic spread of activated Th2. Similarly, this T regulatory cell, though it is injected in one lymph node, but it is having a systemic positive effect. So this systemic positive effect is actually going to the different organs, different sites. So this T regulatory cell itself is moving systemically through the bloodstream into the GI mucosa, into the lungs, into the other different parts of the skin. And ultimately it down regulates, it shuts down everything. That means mast cell, that means eosinophils, that means basophils, that means B cells. So it actually shuts down everything. So this actually produces this immune tolerance. Now, if you just want to compare the difference between non-inflamed skin versus the disrupted barrier. So suppose if the barrier is disrupted, the skin is already eczematous, the skin is already, you can say, like scraped. Then at that time, like a tape stripping method, I will be coming to that. A tape stripping method, the skin is already inflamed or broken or stripped. Then at that particular time, now these are the alarmins which are produced by the keratinocytes. So the defective skin, keratinocytes will produce high levels of alarmins and pro-inflammatory cytokines. Now these alarmins and pro-inflammatory cytokines will actually push the Langerhans cell or the antigen presenting cell, which is bound to the antigen now, towards high increase in the expression of MHC2 and simultaneously CCRX and co-stimulatory markers. And now this high increased expression of CCR7 actually is, you can say, like pro-inflammatory. So whenever the Langerhans cell is moving to the lymph node and it is presenting this allergen to the Th naive cell, ultimately the Th2 pathway is getting stimulated, so the person is getting allergy. So the main message is that whenever epicutaneous immunotherapy is to be given, it has to be given on the intact skin, non-inflamed skin, non-broken skin, which is very much important, Now the question is that whenever we are doing like skin testing, we always say that, okay, you do upper back, you use forearm. So which site is more important? On which particular skin site should one apply this epicutaneous immunotherapy? So the people have done some studies. In this study, the people have tried on the back, on the arm, on the abdomen, on the thigh, and ultimately they have found that back is actually having the best response. So there is a significantly greater expressions of Langerhans cells, T regulatory cells, and Th17 cells on the back as compared to any of the other area. And surprisingly, arm is having actually the minimal effect. So that means the back is the best. And even in the skin prick test also, it is considered that back is considered to be more sensitive. Though for the point of ease, we are doing it on the forearm, but actually back is considered to be more sensitive. In the epicutaneous immunotherapy also, back is considered to be the best area to be applied. Let's talk about safety. So by targeting the epidermis, now epidermis is actually a non-vascularized area. It is not having any blood vessel. It is not having any pain fiber. And you are actually, you can say, like putting the allergens there on the epidermis. That means you are not letting the allergen to go to the bloodstream. And that is why it is considered to be extremely safe. It significantly reduces the risk of allergen passage into the bloodstream, and that limits the systemic allergen exposure and distribution. So it is highly suitable for the treatment of potentially life-threatening allergies like food allergies. Dr. Soumya also mentioned that in food allergies, even epicutaneous immunotherapy has been tried. So it has been considered highly suitable for these type of allergies. Now let's talk about a little mechanism. So the commonest epicutaneous immunotherapy, which has been described in the literature, is the technique is called as Viaskin, Viaskin. Somebody also called as Viaskin. So they both are same. So if you just see in the panel A, so this is the patch of Viaskin, which is there. If I just want to dissect the patch, so just look at the figure B. So in the figure B, this white central circle. So this white central circle is basically a foam. And then on the top of this foam, so this foam is basically having an adhesive thing. So it adheres to the skin in a circular manner. And on the top of that, so it's like a double tape type of mechanism. On the top of that, a backing film is there. So this backing film is actually getting attached like a double tape phenomena on the adhesive foam. And then on the bottom of this backing film, actually you are putting some allergens. And then when you are putting this adhesive foam, circular adhesive foam, white circular adhesive foam on the epidermis, on the epicutaneous layer, then at that time, the allergen which is attached to the backing film, they get some time there and get absorbed. And then on the top of that, there is an adhesive polyurethane which let the backing film to stay there. And then there is a paper applicator which you remove and then you apply everything there. So if you just see in detail what is happening, that this adhesive foam, which is white in color, so this is the cross-sectional area. So this white color one, this is actually producing a closed area. When it is actually producing a closed area, then at that time, the water loss happens. It actually helps like it actually acts like a condensation chamber. So in this condensation chamber, the water loss will happen, the transepidermal water loss will happen. And this transepidermal water loss, with this water loss, which is getting, you can say like in contact with the allergen, which is there on the backing film. So backing film is here and the water, the skin is losing water and this adhesive tape is surrounding. So this becomes like a condensation chamber. And this water loss will actually leach the allergen inside this area. So the allergen becomes more solubilized. And when the allergen becomes more solubilized, then it is taken up by the Langerhans cells, the dendrite of the Langerhans cells, and then it is taken up inside, as I have mentioned you earlier. If you just see the detailed diagram here, so in the detailed diagram, this is a radiological manifestation. So on the left-hand side of your screen, so SC means it is the stratum corneum, E is the epidermis, D is the dermis. So this is the normal, you can say like simple mechanism. So E is telling you about a lot of Langerhans cells which are there, which is something like a light green type of structure, which you can see here in the first panel. In the second one, which is written as a CD1A, when it has been, you can say like stained with a dye, then at that time you can actually visually see one of the Langerhans cell. So Langerhans cell is predominantly present as red color. This is predominantly present in the epidermis, whereas it's some of the dendrites, some of the long legs, they are there going inside the stratum corneum, sweeping the sampling, swampling the environment. So just see this dendritic leg, which is coming out, which is like a receptor for the allergen. Now this green is basically the film, the film which the allergen which you have applied through the film, which I have just explained, the Viaskin. And then this Langerhans cell is now taking up this white arrow. So this is now taking up this green allergen, and then thereafter it is going to present it inside. So all these green one, these are the Langerhans cells which have moved inside, So red one we have just colored it to explain it better, but ultimately they are taking up the allergen and they are moving inside. So you just see they have moved inside. So this is happening. So targeted allergen-specific immunotherapy within the skin improves allergen delivery to induce desensitization to peanut. Dr. Soumya also mentioned that APIT has been predominantly described for peanut. So this is 22 therapy. So APIT delivery system, this is like the adhesive patch I have just mentioned you. This is the conventional APIT. But now there are modifications to APIT also. What people are saying that instead of keeping the, you can say like the patch above, you use some micro needles. And these micro needles can go a little deeper. They can probably go up till the epidermis, or they can probably go up till the dermis to, you can say, like better deliver the allergen. So like for an example, you are doing the skin prick test. In the skin prick test, you are delivering at a depth of 1 millimeter. So they're also trying to go a little depth of 1 millimeter, and then whether they can produce the things in a more better way. So now these micro needles could be, you can say like allergen coating could be there, or they could be having, you can say like coating outside, and then the needle can be removed, and then the allergen stays in the skin. So this could also be there, so which is called as a micro needle delivery system, which is a type or a modification or advancement of APIT. So this is one study in which what people have seen that they have, you can say like sensitized with the peanut, the people are sensitized, or the children are sensitized with the peanut, and sensitized children they have taken, and now they have applied immunotherapy. So these different type of immunotherapies, they have been applied. So one is PBS. PBS is basically like a placebo. Then PN EPIT. PN EPIT is basically conventional epicutaneous peanut immunotherapy. Then OVA, basically OVA albumin microneedle. So this is once again a placebo for the microneedle and the peanut which is attached to the microneedle. So here there are two placebos. One is a placebo for the EPIT and one is placebo for the microneedle. And what they have found is that among this, the peanut which is attached to the microneedle or delivered through the microneedle, this is definitely having the best, I will say, you can say like the evidence. So more ear swelling is there, more reactivity is there, more chances of reactions are there, and SPTV is quite higher. But simultaneously, there are more chances of, you can say like interleukin 4, interleukin 5 suppression, and the good interleukins, they are produced more. Interferon gamma is produced more in this microneedle technique as compared to the conventional EPIT. So they both are good as compared to placebo, but microneedle is still better as compared to the conventional EPIT. Whether it is a safe technique. So this is one study which is called as the REALIZE study, which is an open label study which has been recently published in 2025. And this is the abstract of the study, in which what they have done, they have taken 393 children aged 4 through 11 years, and then they have divided them into 3:1 group. So one means like 25% of them acted as a placebo, and three means like nearly 3/4 of the children acted like a test children, and where the Viaskin was applied, this VP250, this Viaskin was applied, and after 6 months, then once again they have given Viaskin to everybody. And what they have seen that about the serious adverse effects, so the local skin reactions were the most common treatment-related effects, but they also decreased in frequency over the years. And there was these all skin reactions were actually more milder skin reactions, and nothing was there actually which is continues to be, you can say like a serious reaction, except one where they recorded like treatment-related anaphylaxis in 4% of the cases, which is very less, and that is also during the acute treatment or active treatment of first year. Then EPIT for food allergy. This is a systematic review and analysis, once again published in 2025. So this also suggests that the desensitization events with EPIT versus non-EPIT, that means either your subcutaneous or oral immunotherapy or any other. So EPIT seems to be, you can say like winning the race here as compared to the other therapies. And similarly, the local adverse effects are much lesser in the EPIT as compared to the others. And systemic adverse reactions are also much lesser in the EPIT as compared to the previous reactions. So what about EPIT over striped skin? So as I mentioned you that you go with a microneedle technique. So you can always question, okay, I will just put a tape, I will stripe the skin, and thereafter I will apply EPIT. So that will not work. That will in fact become allergenic, because I told you that any broken skin, any breached skin, that will become more allergenic. So this study also says the same thing. If we just see that the stripping with EPIT has actually increased the specific IgE, it has actually reduced the IgG concentration, it has actually increased the IL-4, and means like the other harmful interleukins, and interferon gamma production is also reduced. So similarly, the IL-5 is also more, IL-13 is also more. So the study concludes that EPIT through repeated applications of allergen should be performed on a normal, non-inflamed skin, intact skin, in order to ensure the safety of the treatment by avoiding a massive free passage of the allergen into the bloodstream, but also to induce a tolerogenic immune profile. So the different innovative techniques have been described recently in 2023 for EPIT. These are the 4 types. The first one is the Viaskin, which I've just mentioned. Second is the microneedle. Among the microneedle also, there are some advancements. So the people have used solid microneedles, coated microneedles, dissolving or core shell type of microneedles. And then this is another technique which is called as precise laser epidermal system. This is also called as PLEASE technique. So precise laser epidermal system, in which what they have done is that they are using the laser beam, and through the thermal heating, which is very mild heating, they're actually creating some minor pores in the skin, which are, you can say like non-painful, which are non-inflammatory, and they are targeted pores. They can actually target to the epidermis, they can actually target to the dermis, they can actually target the depth. And then thereafter, they are applying the allergen, and then allergen is going inside, and then it is producing effect. Or the people have now come up with the nanosystems. In the nanosystems, there are several adjuvants which they have used, and these adjuvants, when they are getting combined with the allergens, then ultimately they are actually helping in better absorption, targeted absorption, more better suppression of Th2 response, or more better T regulatory cells. So this study, like the delivery system I just mentioned about the PLEASE, which is a laser system. So the people have seen the different outcomes the people have seen. about, so the duration could be once weekly for 8 weeks, twice weekly for 3 weeks, once weekly for 3 weeks. So all these are somewhere around 4 to 6 weeks or 8 weeks duration, not more than that. And they have seen several beneficial effects by different delivery systems. So all these delivery systems, I'm not going in detail, different outcomes which have been prescribed. So coming to the pros and cons of different APIT systems. So if I just combine everything together in one slide, so these are the 4 systems: via skin, please, microneedle, and nano system. And what they have seen that there are several advantages. So in which there is a high safety profile to the allergen for more or less everything. There is no serious adverse effects which has been seen, no visible long-lasting damage to the skin, and there is low cost intensive as compared to the conventional AIT. So this is, everything is good, but there are certain limitations also. That means the limitation is that it is actually limited to the large molecule drugs only. That you require a prolonged patch application there. So then this needle system or the pleat system, laser system is sometimes inconvenient and highly costly to the patient. So there are certain limitations to these also. So the limitations of APIT are that limited allergen dose delivery. It is slower onset of tolerance. So the onset of tolerance is actually slow in APIT, and that is why APIT requires a longer duration of therapy. Variable skin absorption, that means skin thickness, hydration, and barrier function. This will also depend. Like we understand, on the one hand, I am saying that in food allergies, those children who are at risk of serious reactions, anaphylaxis, APIT is good. But on the other hand, I am saying that food allergy itself many times presents with eczema. The skin is dry, and you require a healthy skin to deliver APIT. So you need to really see that what you can do. Mild but frequent local reactions can happen. Longer treatment duration for efficacy, months to year, is there. And allergen formulation constraints. Currently, it is limited to only peanut, certain grass pollens, and dust mite. And we actually want more studies with different allergens in different age groups, and then cost and availability also another issue. So for APIT, summary is there is no APIT platform is FDA approved yet. Numerous encouraging studies suggest APIT could be a future for both respiratory and food allergies. Addition to an adjuvant like in nanoparticle system in APIT represents another strategy to enhance efficacy and safety. So if I want to summarize the intralymphatic immunotherapy as well as APIT, so in summary, intralymphatic immunotherapy targets lymph node directly, requires only 3 injections over 8 to 12 weeks, rapid onset of clinical improvement, weeks instead of months, lower total allergen dose needed, possibly reducing side effects, and greater patient adherence due to short treatment duration, whereas APIT, it delivers allergen through intact skin using patches. It's needle-free, painless, highly suitable for children. Continuous low-dose exposure mimics natural tolerance induction and lower systemic reactions compared to SCIT. So, well, I have spoken about intralymphatic and epicutaneous immunotherapy. So I thought that let me speak 3-4 slides about the further new modalities which we can probably expect over next 1 decade or 1.5 to 2 decades. We can probably bypass the Ig binding using certain different techniques. We can do allergens fused with immune response modifiers or allergens coupled to adjuvants. So what are the future directions? It could be like defined molecular vaccines, like recombinant allergens and peptide vaccines, which can actually reduce Ig binding while preserving T cell epitopes. Then precision adjuvants and immune skewing formulations, which can actually bias the response towards Th2 pathway by TLR agonist or CpG agonist, and ultimately the Th2, nobody is actually going towards Th2. Then nanoparticle technique, which I have just mentioned you, and these could be with the liposomes or polymers or virus-like particles. They can actually allow targeted delivery to the tolerogenic antigen-presenting cell, and they can actually help in control release with improving potency and reducing local and systemic reactions. We can also combine biologics. Dr. Soumya already mentioned about combining biologics, different type of biologics with especially omalizumab, which is available to us. So with the conventional immunotherapy regimes and the newer immunotherapy regimes. So what biologics can do, they can actually blunt the immediate hypersensitivity response, and ultimately it provides you a window. It provides a safer window or a window of opportunity for rapid escalation of your immunotherapy and ultimately desensitization. Then we can also hope for cellular engineering with T regulatory adoptive transfer and CAR therapy. So this CAR therapy is actually now you can say like making a boom in oncological conditions. So similarly, we are hopeful with this CAR therapy, that is antigen-specific regulatory cell, which are engineered for stability and homing. They can induce a targeted immune tolerance without any global immunosuppression, which is possible. Tolerogenic dendritic cell therapies and dendritic cell targeted vaccines. This is also possible that we can probably you can say like devise something which are actually targeting towards tolerogenic dendritic cell, and they are not, you can say, letting the allergenic dendritic cell to strive or thrive. Then microbiome modulation. Microbiome is something which is the talk of the town, and I will say the talk of the world. So whole world is now working towards, thinking towards microbiome. So microbiome modulation and adjuncting with microbiome predicts. So can we combine some of the prebiotic or postbiotic or some sort of microbial adjuvants along with some immunotherapy or something, and can we do something to probably induce the tolerance? Mucosal targets and novel route innovations like oral mucosal formulations, intranasal formulations, improved APIT patches. Can we do something like that? Then biomarkers, Dr. Karthik already spoken about that. Endotyping and personalized AIT protocols. Can be used some component resolved diagnostic? Can we use some cytokine signatures along with the clinical endotypes to choose the best allergen immunotherapy for one particular patient or other patient, which could be different? Shorter or high efficacy regimes could be optimized elite or APIT hybrids, or controlled release depot can come up, or probably gene editing. This could be something which is very fascinating, and I really hope that another 1 decade or 2 decade, we should be reaching up till that extent. That gene editing, that means probably you have edited the gene, and then thereafter, like for an example in cat, this CRISPR technique is used in which you are editing the FELD1 gene, and ultimately the cats are produced with lesser, I will say, the FELD1 allergen. So they are becoming non-allergenic. Similarly, for wheat-dependent exercise-induced anaphylaxis. Now, the different, I will say, the varieties of wheat which are produced, which are, you can say, like genetically modified. And this genetically modified, what they are doing is they are reducing, these cell lines are reduced for omega-5 gliadin cutting and all these, and ultimately they are becoming more better. So then digital health, I think Dr. Karthik has already enumerated that, not going in detail. Focused clinical trial designs and regulatory and manufacturing advances for standardization. So the roadmap for clinicians and researchers could be combining all these things together, probably biologics and AIT for now, for high risk group. The legends like Dr. Somya, she's already using it, and we are learning these. Push nanoparticles and carrier platforms in APIT and elite studies. Develop antigen-specific cell therapies like T regulatory cells and CAR T regulatory cells. Invest in biomarkers. I think future is for biomarkers. We need to really invest in biomarkers and endotype guided RCTs to personalized therapy, and translate tolerogenic dendritic cell platforms from autoimmune into allergy trials. So this is the time for precision medicine. We need to now is the time that we need to move our practice from mass practice to the personalized medicine. And every single patient, every single child is different. Even a same patient on a different time period could be different also. So with this, I would like to stop here, and thank you very much for the patience listening.
Thank you, sir. Thank you for doing what you do so well, making such a complicated topic so simple in easy words. Thank you so much. Sir, we are at 10 o'clock. I thought I will just take one extra question, what was coming up in your talks, and we'll conclude with that. Dr. Neeraj, sir, the question for you. Sir, I read about types of extracts that aluminium absorbed, tyrosine adherent, and aqueous extracts. Can you please tell us if there's anything difference in this type of extracts and their efficacy with intralymphatic immunotherapy?
So as I mentioned, that these all are the adjuvants, and these all adjuvants are actually used to, you can say, like enhance the efficacy of, you can say, like and these extracts, and simultaneously they are also trying to reduce the allergenicity. So all these adjuvants are targeted like that. So these are only not these three names. There are several other things which have been now combined, and so several studies are there, and which are actually comparing one adjuvant against the placebo, another adjuvant against the placebo. So they have found to be, you can say, like useful, but once again, the studies are limited, they are handful, and they are more costly. So we need to have more data, and which one is more better, then only we can answer it in a more better way.
There's one more doubt I had. Does the site, because this intralymphatic immunotherapy, there are various sites. There have been sites where there's cervical intralymphatic as well as inguinal, which is more common. Does it matter based upon where is the site, as the aeroallergens go in the nose, and these are more exposed to the aeroallergens as compared to the intralymphatic, which is given in the inguinal lymph node? Is there any difference, or more efficacy better?
So people have actually studied different sites for the lymph nodes. Like I mentioned about the epicutaneous immunotherapy with the back and all those things. So people have studied different lymph nodes also, sites also, and they have found that inguinal lymph nodes are more accessible. And it is not the local effect; it is the systemic effect by the lymphatic spread and by the systemic circulation of the T regulatory cell which is happening. And that is why it is, you can say, like from the efficacy point of view, it is good, but from the feasibility point of view, it is the inguinal lymph node which seems to be much more feasible. And simultaneously, the size of the inguinal lymph node is also a little larger as compared to the cervical lymph node in the physiological condition. So holding up a lymph node, injecting it inside the needle, you actually require a certain size of a lymph node, and then only you can proceed the procedure. So looking all these things, the studies are saying that this inguinal lymph node seems to be the better choice as compared to any other site.
Thank you, sir. Thank you so much. Just take the questions for Dr. Karthik. Dr. Karthik, the question which I told I'll discuss with you was, as children naturally outgrow allergies as they grow, do the same responses happen as with allergen immunotherapy? Does the same response happen? Do the IgG4 antibodies actually increase? Is that how children outgrow immune responses which they were reacting to as a child? Or is there any other way which happens and this immunotherapy induces any other way?
So, actually, excellent point. What we try to achieve with allergen immunotherapy is try to mimic the same natural tolerance that we generate over time. And just like how children, they tend to overgrow certain allergies, particularly related to food allergies or certain aeroallergens in the earlier phase of their life. It is basically based on several factors. One of the most important one will be the dose of the allergen exposure. Some large allergen exposure doses are similar to your allergen immunotherapy exposures. So when children have been exposed to large allergen exposures, similar changes with the Treg and Breg, regulatory cell mediated antibody, or what do we say, the inert antibodies like IgG1, IgG2, IgG4 are predominantly shown in these studies. So if you look at it, allergen immunotherapy is basically trying to reproduce the same natural process after a massive allergen exposure. So yes, that would be technically the right answer. But when you look at allergen immunotherapy, it operates on multiple levels. It also works on, depending on the site of exposure, it has different antibody productions. It also acts on your ultimately your basophils and also on your cytokines, which are responsible for MHC2 targeted therapy. So there is a slighter modification, but it does not replicate completely the natural tolerance, but it is somewhat similar when it comes to IgG4. Yes.
Thank you, Dr. Karthik. Dr. Soumya, just one question. When we have multiple food allergies in children, which we do commonly encounter, how do we choose like which food to go with first? And is it just based upon how much the reaction is or how common the food is, or how do we choose?
It's in the context of oral immunotherapy.
Oral immunotherapy, yes, ma'am.
Yeah, so generally, I think when we are talking about oral immunotherapy for food allergies, I would choose the food which is clinically more relevant to the patient and for which they had a more severe reaction. And the chances that they would possibly not outgrow that food allergens, and the component testing and the history is also suggestive of the same. I would probably choose that food initially for oral immunotherapy. And if required, we may add on another food through the journey of one food OIT. Though multiple food OITs are a little less common subsequently to start together. But once you're in the one maintenance phase of one food, we could possibly think of the immunotherapy for another food subsequently.
Ma'am, is there any way we can do both types? I mean, I'm just asking randomly, like oral immunotherapy for, say, one food and then epicutaneous for another food. Is it possible? Does it make sense? Does it happen? Anybody? Dr. Karthik, Neeraj sir, anybody? I'm just
I think
thought right now.
the future is bright because we have more options for us. Like we have epicutaneous or sublingual immunotherapy also. I think possibly we could be doing that in the future. But for now, I think the data is very restricted.
Yeah, so agree with you, ma'am, on that. As of right now, I think we are starting with single route of therapy, with single food first, which is the most important food, as in something that is most likely to be accidentally consumed. In that aspect, if you look at it, milk or egg would be somewhere on the top of the list compared to the rest of the food, right? So the chance of getting a reaction, accident or non-accidental exposure, will be my one of my top priorities in addition to your thing. So yes, there have been some patients where we had to use two different routes of therapies, but it is not routinely recommended. This is completely done only at, like, research oriented, or or only in places where there's a lot of experience, like how some has a lot of experience on OIT. Certain cases we have successfully done sublingual immunotherapy to milk, and oral immunotherapy to wheat. This has been attempted, and we have been able to reach that. Although there are two different modes, there are two different indications. One was with anaphylaxis, one was purely with certain types of milder IG mediated reaction. So these are all case reports, they are not general recommendations.
Thank you, Dr. Soumya, Dr. Karthik. Neeraj sir, do all the modes of, like today's, we discussed so many modes of allergen immunotherapy, the SCID, the SLIT, the ILIT, the EPIT, oral, do they all induce the similar immune responses, or do they have different immune responses based upon the route in which they're given? Do they all induce the same response?
No, ultimately the immune response is same. Actually, it is means like the way how you present to the lymph nodes, or you can say the lymphatic system. That is the main important thing. Once the allergen has reached to the lymphatic system, then thereafter the response will be similar. But before reaching to the lymphatic system, how much dose, which environment, whether it has been spilled in the systemic circulation or not, whether it has already created some TH2 pathway, mast cell activation or not. So that will actually determine so many other things. But ultimately, once it has reached to that particular, you can say like TH naive cell, then at that time the immune response will be similar. That will not be different.
Our panel was on blueprint for building AIT clinics in India. So essentially, that blueprint had, when I read all over the world, there were some 5 or 6 steps on the in the blueprint for development. I just go through one of the questions which I had in that. That's all. How do you identify the demand, sir, for setting up an allergen immunotherapy clinic? How do you identify this demand, Dr. Neeraj?
So first of all, we need to really understand that this particular specialty, allergy specialty, is a separate dedicated specialty. And we need to really understand that those people who want to practice allergy, then they should practice only allergy. They should be dedicated to that particular thing only. It is not possible that somebody can say that, okay, my 50% practice is this and 50 is this or 10% is this, 90% is this. It's not like that. If you are doing something with dedication, then at that time you should be so much focused with that. Then thereafter you have to, you can say like, if you are so much focused, then thereafter you need to really see that what is the population you want to tackle, which particular diseases, allergic diseases, what modalities you want to provide, and depending upon that, then you will identify the needs, that these are the needs of the population. Like for an example, right now in India, respiratory allergies are predominant, we all understand. We understand that in coming years food allergies are going to come, and then there are certain other things which are hidden, probably some insect allergies, probably some drug allergies, so they also need to come. So if somebody wants to start something, then they will start as a newcomer, they will start with more predominant problem like respiratory thing. Then thereafter, once he is more stabilized in few years, then he will move to the next step, then he will move to the next step, something like that. And now whatever things he want to do, like for an example, somebody wants to do skin prick, somebody wants to do, you can say like immunotherapy, or probably some pulmonary function testing. So depending upon that, so which type of clinic they want to make, whether they want to make it like a tertiary care referral type of a clinic, whether they want to make like a primary care type of a thing. So depending upon that, they will identify their needs, and then they will go with the modalities which are required there. But my only humble suggestion is that if you want to practice something, then do it wholeheartedly. If you are doing it half-half, then I don't think that you are doing justice to anything.
Thank you, sir. Soumya ma'am, one question on this blueprint. What all, considering you are doing oral immunotherapy, I mean, all of you are, what is the basic infrastructure you will need and the safety measures and all for setting up an AIT clinic?
I think, as both my panelists have been emphasizing, I think when we are talking about AIT clinics, it's important that even though the risk of reactions are very low, even theoretically, but we must be prepared for it. And we must make sure that facilities are in place for the same. It could be a simple crash cart, make sure we have all the emergency medications on standby. We have equipped staff where we have run mock drills and they are equipped to deal with any minor unanticipated reactions, if any, and the patients can be appropriately managed. So I think it's important that initially when we are starting the AIT, be it for um, other modalities of or allergen immunotherapy such as subcutaneous or oral immunotherapy or epicutaneous or intralymphatic, I think it's important that we are confident in choosing the patients correctly and managing the drawing the protocol personalized to that particular patient, and also discuss the possibility of any minor reactions also with the patient so that they are also mentally prepared, medico-legally be safe, take consent, document, keep a copy, give a copy to the patient if possible, and have all the emergency medications on standby, run mock drills, everything. I think it's important to anticipate even though the risk of reactions are very less.
Thank you, ma'am. Thank you so much. Dr. Karthik, the last one will wrap up after this. In your center, what all have you felt as the regulatory or the licensing procedures? Is there anything like that which is needed while setting up or building up an AIT clinic? What is needed to be done for as a blueprint?
So I think what is important when we look at from AIT, like already Sir and Madam has spoken about, is not just having a dedicated center for diagnosing, but also for able to, go ahead to the next step, like therapeutics. That is what you look at. Some of the issues that we tend to face are most important one would be your allergen extract. That is the biggest question that we have in India also. Is the allergen extract something that is going to be prepared patient labeled product, or is it something that can be prepared personalized to the patient at the unit also, which is practiced both in different parts of the world. Different practices are present. So which one is legally binding, which is not legally binding, is something that to be looked at. Ultimately, at the end of the day, allergen practices, immunotherapy, if it is there, standardization of consent forms and standardization of immunotherapy practices, as in how you prepare the patient, how you take the consent, how you are administering the allergens for your extracts, what protocols you use for managing them, that needs to be more standardized, and that training needs to be much more standardized. Third thing that I would look at is, yes, managing the ultimately the side reactions. Are you well equipped to prepare to identify reactions, and are you going to do it? So some of the things that I would look at are we doing any pre-testing before giving immunotherapy? Like, are we doing PEFR or PFTs, or are we doing any simple questionnaires before or after administering immunotherapy on every visit, and close monitoring of every patient. I think we need to have nurses, nursing supervisors who are able to identify even a simple first symptom so that you can address it immediately. Some of the places where I've seen are like, nurses are able to just initially undergoing oral food challenge, child develops a single sneeze, and it could be within seconds that they start developing an anaphylactic reaction. So that identification and treatment, that is also be going to be something useful. So when we look at it from an algorithm point of view, standardization of allergen extracts, preparations, legalization of which extracts and how to administer them under your practices, use the ones that are accepted internationally, guideline based, and obviously consent and identification. I think those would be the standardization that I would focus on.
Thank you, Dr. Karthik. So that was an excellent external discussion, 3 sessions, lovely sessions, and a very, very crisp panel, I must say, to conclude the session just
Dr.
within time.
Soundare, allow me to interrupt here. I
Tell
think
me, ma'am.
it is our duty to also thank you for a very wonderful moderation
Thank
and
you,
a
ma'am.
very
Thank you.
meaningful
Thank you so much.
questions. Thank you.
Thank you so much, ma'am. Thank you. So thank you all once again for participating so actively, for indulging my questions. Thank you, Neeraj sir. Thank you, Dr. Karthik. Thank you, Dr. Soumya. Thank you so very much. So with that, we will conclude this session.
I usually say that the success of a panel is actually depending upon the moderator, and it is the
Thank you,
moderator.
sir.
So moderator who is smart, then everything becomes very good. So
I don't think so, sir.
whatever you have spoken, so everything is only because of you. So
Thank you, sir. Nevertheless, you indulged me as well. Thank you. Thank you so much.
Thank you. But I really enjoyed this series actually. Means like
Yes,
the
sir.
entire series of 5 webinars, allergy and immunotherapy, almost 10 hours or more than 10 hours, nearly 11 hours of webinar in last 8 days or 7 days. It's something like a marathon run, and means like really a you can say like a wonderful galaxy of speakers. I must say that 20 people we got together, the finest people about allergy and immunotherapy, both from the adult side, ENT side, pulmonology side, pediatric side. Everybody came together just for a common cause. So I think, and everything is available on the YouTube. So anybody can go there and then have, you can say like once again, relook at it. So many things which even I learned on each and every webinar. Today also, today's session, both of my previous speakers were really truly amazing. I must say, truly amazing. They have done so wonderful. Thank you. Thank you, everyone. Thank you. Thank you for doing that. Thank you.